My dear doctors, welcome at Dr. Rami Cardi Club. Today I would like to present for you a super interesting clinical scenario that's very important, very high yield for your exam. Here we go. We have 55 years old gentleman presenting to emergency room with a sudden onset of crushing chest pain radiating to back. Sudden onset crushing chest pain radiating to interscapular area. They are the same. He looked sweaty, pale, and dizzy. Okay. On examination, his blood pressure was 180/110 on right side and 160/80 on left side. This is important because I'm thinking now of what? Yes, exactly. I'm thinking of dissecting aortic aneurysm. Dissecting aortic aneurysm. Sudden onset of chest pain radiating to interscapular area with unequal blood pressure, unequal pulse intensity on both sides of the arm. This will be translated into dissecting aortic aneurysm, which is a very critical situation. His heart rate was 112 beats per minute and was regular. Chest is clear to auscultation bilaterally. No murmurs, raps, or gallops could be listened over precordium. Abdomen is lax, non-tender, and no organomegaly. His ECG is shown below. What is the most important medication to give at this moment? Nitrates, beta blocker, aspirin, ACE inhibitor, verapamil. Before we pick the choice, let's see the ECG of the patient. What do you see? Yes, exactly. Look at the inferior wall. 2-3 AVF. ST elevation. Look at the anterior. V1 to 4. ST elevation. This is anterior ST elevation MI, with reciprocal changes in the lateral leads. 1 AVL and V6 has ST depression. So, what is your diagnosis here? My diagnosis is dissecting aortic aneurysm complicated with dissection of coronary artery origin causing MI. So, what is the medication you start with? Oh my God. MI means aspirin. If you give aspirin to this patient, you're gonna kill him. I'm gonna be the killer. Don't give it, please, because we are suspecting dissecting aneurysm. Dissecting aortic aneurysm, if you give aspirin, you will increase the dissection and push the patient into death. Nitrates to relieve pain. It is one of the medications we're gonna give, but not the first one to start with. Beta blocker, maybe. ACE inhibitor, does it has any rule here to start with? No. Verapamil? No, verapamil will be important if we are suspecting parenchymal angina, coronary vasospasm. This is not the case. Beta blocker is the medication of a choice. Beta blocker, IV beta blocker. Usually we give IV lapitalol, will be the drug of choice in dissecting aortic aneurysm because it will decrease the shearing force on the wall of the aorta and lower down the blood pressure. That would relieve the pain along with using nitrates. So I would like to talk about beta blocker in some important points that's very important for your exams. Beta blockers is so loved by cardiologists. Actually, we think that God in the beginning of the world created Adam, Eve, and beta blocker because we love it so much. It is essential for treatment of ischemic heart disease. Actually, in the European Society of Cardiology, this is the first line anti-anginal treatment. The first line is not nitrate. The first line is beta blocker. In the treatment of heart failure, it is essential, in addition to ACE inhibitors or ARBs and aldosterone antagonists, in the treatment of hypertension, in the treatment of arrhythmias and control of heart rate, different types of tachycardia, sinus tachycardia, atrial flutter, atrial fibrillation, so supraventricular tachycardia, atrial tachycardia, all of them can use beta blockers. Pregnancy, does it have any role? It's not contraindicated in pregnancy. I told you before in another video that ACE inhibitor, ARBs, cannot be used in pregnancy, but actually beta blocker can be used, especially lapitalol. In aortic aneurysm, dissecting aortic aneurysm, you can use beta blocker. This is the first line medication. Okay. I would like to talk shortly about the pharmacology of beta receptors and beta blocker. Beta receptors are present in the body as beta 1 receptor, which is a stimulatory, beta 2 inhibitory, relaxing, beta 3 stimulatory too, like beta 1. Beta 1 receptors found in the heart carries inotropic, chronotropic, thrombоtropic cardiac effect. So if you give beta blocker to the patient, you're gonna guarantee that you have decreasing contractile function, decreasing conduction through the AV node, and decreasing heart rate, and decreasing conduction of electric signals from the sinus node to AV node to his Purkinje system to the ventricles. So it will slow down the heart rate. Actually, beta 1 receptors are present also in juxtaglomerular cells in the kidneys, which is responsible for the renin release to activate the angiotensin system, which is responsible for raising the blood pressure. So beta receptors had this role to inhibit renin release and control blood pressure. Actually, in the treatment of hypertension, beta blockers are not the first line treatment to start with. The guidelines has taught us to use it if the patient has hypertension and ischemic heart disease, hypertension and heart failure, hypertension and chronic kidney disease. Beta 2 receptors, relaxing the blood vessels, relaxing the bronchial tree. Beta 3 receptors present in the blood vessels also, adipose tissue and gallbladder. So pay attention please to adipose tissue, because as you will see in the next slide, beta receptors may worsen the lipid profile of some patients because they have effect on adipose tissue. They inhibit lipoprotein lipase function, and the triglycerides will be accumulating, so they cause hypertriglyceridemia. Also, beta receptors are present in the beta cells of Langerhans of the pancreas, which is responsible for release of insulin. That's why beta blockers may worsen the hyperglycemia of patients with insulin resistance, because they inhibit the release of insulin. So they may worsen the control of blood sugars. That's why beta blockers are not favorable in the management of hypertension with diabetes, because they worsen the hyperglycemia, and if the patient is going through hypoglycemia, they mask the hypoglycemic symptoms, because hypoglycemia stimulates the sympathetic nervous system, and the beta blockers are sympatholytic. They are antagonizing the sympathetic nervous system. So they slow down the heart rate, which is the first sign of hypoglycemia, tachycardia, that will be inhibited. Patient may not notice that he has hypoglycemia. So let's see some perils that's very important in MCQ questions. and in oral discussions. Beta blockers are contraindicated only in bronchial asthma, not COPD, as it is written in the guidelines. So in patients with COPD, you can use beta blocker. In patients with bronchial asthma, you cannot use beta blockers. May mask symptoms of hypoglycemia, as I told you, in patients with diabetes. That's why it is not the first choice in this scenario. Beta blockers causes poor control of diabetes. All generations of non-selective beta blockers may worsen lipid profile, especially rise of triglycerides and having HDL low, especially in smokers. The secret behind being cardinal in coronary artery disease is they are decreasing oxygen consumption. This is very high yield in the exams because I may tell you that I have a patient with ischemic heart disease and I have decided to prescribe beta blocker for him. So why I'm prescribing beta blocker for a patient with ischemic heart disease? I will give you choices. I will mention because it is slowing down heart rate, it is decreasing contractile function, it is allowing coronary filling time to be prolonged, or it is decreasing oxygen consumption. Decreasing oxygen consumption is the result of all these factors. So if you have it in the choices, this is the correct choice. Just take it. This is guarantee. Labetalol can be used safely during pregnancy. That's why beta blockers are so loved by us, my beloved doctors. I wish you loved this session. I wish you the best of luck. Bye bye.